University in Atlanta, Georgia. Her clinical and research interests are focused on Fabry disease. She is a co-founder of Think Genetic, which empowers patients who want to know about possible genetic causes for their medical issues or obtain real-life answers to their questions about the impact of living with a genetic disease. Dawn also enjoys writing children's books, most of which are about living with Fabry disease. It is my absolute pleasure to hand it over to Dawn.
Good morning, everybody. Sorry for my delayed arrival. I thought we were doing this an hour from now, but that's fine. I'm happy. I have some exciting things to go over with you. I'm going to share my screen here, and we can talk through some of the things that I found very interesting at the meeting this year. A little disclosure, I tend to focus on things that are happening now. A lot of things we learn about at the World meeting have to do with future things that will come down the road. So research that's done in mice, research that's done in test tubes. And I like to comment on those if there's something exciting happening there. But the difference in what happens with us in a daily life and what happens when we're looking at studies that are directly applicable or applicable in the next couple of years makes a big difference. So in this case, I'm focusing on things that are really exciting right now. And there are a few things where I am looking here, looking at that will be coming soon, but are not quite here yet. All right, I'm resharing my slides. There we go. All right, how's that look to everybody? Does that look good? Good, all right. Here are my disclosures. And here's the disclaimer I just told you. My plan is to very quickly go through some things about Fabry disease so that we're all on the same page. When we talk about new developments in Fabry disease from the clinic, from trials, from the laboratories, I think it's important to make sure that I kind of mention the basics and then we go dive straight into what's going on. You'll see at the conference there was a lot of discussions about COVID and Fabry disease, so we're going to go through that. And then just some new information about how we understand Fabry disease and a little new information about approved therapies that are out there for Fabry disease and therapies that are currently in clinical trials. So I'm going to start off with the real basics, and I know many of you are very familiar with this, so I'm going to go quickly, but still enough that we'll have the same starting ground. Cells, as you know, are the basic building blocks that make up our body. And there's different types of cells, like the ones that line the blood vessels called endothelial cells, or the cells, the deep filtering kidney cells called podocytes. There's many other types of cells in the body. When we talk about Fabry disease, you'll see we talk a lot about endothelial cells, podocyte cells, and other types of cells. In every one of these cells, there are lysosomes, and the lysosomes are the recycling center of the cell, in which we have different enzymes that break things down. And the instructions for building these enzymes are within our genes. And their genes are lined up like beads on a string for chromosomes. And the one that we think about most in Fabry disease is the GLA gene. And that GLA gene is on the X chromosome. And changes in that GLA gene is what cause alpha-galactosidase enzyme in the lysosome not to work. Alpha-galactosidase A is an enzyme that our body should make in the lysosome to break down big, complicated molecules. But in Fabry disease, as you know, it does not. And what it's supposed to break down are molecules called GB3, or globotriacylceramide, and lyso-GB3. These are both big, complicated sphingolipid molecules that you want to break down so you can use them in the body or take the pieces and remove them from the body. I like to call them gunk, you know, stuff that builds up if it doesn't get cut down. This gunk affects those endothelial cells I just mentioned, as well as podocytes. It decreases the size of the blood vessels by the lysosomes in the walls of the blood vessels getting narrower and narrower. And it also irritates it, which can cause inflammation or the body to consider these cells not functional. And it's not just the storage that causes problems, it's all the things that come after that. After the cell is irritated, it sends out signals to the whole body, and that leads to scarring and cells that end up dying, and leads to problems with your body not knowing if it should be fighting something or if it should be functioning and making energy. And as we've learned more about Fabry disease, we've learned there's a whole spectrum of ways people can have Fabry disease. In classic Fabry disease, that would be our more, we kind of know what the path looks like, and it tends to have onset in childhood, tends to lead to earlier organ problems. And then across the spectrum, you can have people who are affected all the way across what it looks like, until you get to non-classic Fabry disease, which is still very life-impacting, life-limiting, but it doesn't tend to start as much in childhood. Now, it also sometimes may not have angiokeratomas or may not have nerve pain, but as you know, nobody follows these rules. Our bodies do what they're going to do. And so you can have Fabry disease that's somewhere in the middle of this as well. But when we try to talk about classic, we're trying to think about the earlier onset form of Fabry disease, and non-classic would be later onset. Okay, now that we're all on the same page, let's dive on into those updates. One of the things that we were very concerned about when COVID came approximately a little bit over a year ago, the question was, is Fabry disease a risk factor all by itself? We know that diabetes is a risk factor. We knew that kidney disease was a risk factor. Is Fabry disease just on its own also a risk factor? The good news over the past year from international studies and international patient data, we've learned that Fabry on its own does not give you increased risk for COVID, severe COVID disease. What does that mean? That means that you could have a COVID course like any other individual, even if you don't have renal failure or heart disease, but that we're not worried about Fabry disease automatically causing you to have more severe critical disease and ending up in the hospital with pneumonia. We do know, though, that everybody has a risk for COVID disease, and the risk goes up depending on other factors in the general population or the Fabry population. So we still have the same recommendations for masking, stay at home, and social distancing. Just because Fabry isn't a risk factor on its own doesn't mean we don't need to be as cautious as we were before. Looking at that real world data, there was several posters, and this is the one that had the biggest cross-section of international data on patients who had Fabry disease. And the way that they divided this up in the paper was to look at people who had end organ damage, so kidney disease, heart disease, not proteinuria on its own, but further along the path, so reduced filtration rate, people who had left ventricle hypertrophy, and then compared what type of symptoms they had of COVID when they were affected. Now, COVID can be very serious in any individual, and this is what we saw with our Fabry patients as well. But for the most part, individuals with Fabry disease, women, men, children, classic, non-classic Fabry disease, had more mild and moderate disease. Disease that definitely caused problems like loss of smell and appetite, fatigue, cough, muscle pain, and in our case with Fabry disease, pain crisis with the fever that occurs. But most patients didn't have severe complications that took them to the hospital or resulted in death. There were 2 patients who had severely progressed Fabry disease who did pass away from COVID-related complications. One of the patients had significant heart disease. The other one had heart disease, strokes, and had renal failure and was living in a rehab facility. And so despite fighting in both cases, these individuals who are already pretty sick with Fabry-related complications did succumb to COVID critical disease as well. So when you're looking at a risk for someone who has Fabry disease and you're thinking about how do we figure out if they could be in this higher risk, this lowest risk category, the group of folks who got together to write this article, this international article on COVID disease and Fabry disease, all got together and made basically this triangle that helps you kind of look at the symptoms you have, the age that you are, other risk factors you may have, and determine if you are at risk of severe or critical COVID-19 disease, or if you're at more general population risk. And you can see here that by moving up and down the sides, you can figure out where you may fall in this particular location for risk of COVID disease. Is it perfect? No. You each have individual risk factors. Everybody has a different immune system, but this is a way to kind of help you understand and help healthcare providers understand where you may fall, looking at Fabry disease as well as your normal health. In all cases, we recommend everybody with Fabry disease take the precautions that are recommended by your country. Here in the States, we've got the CDC who gives us nice recommendations related to mask wearing, washing hands, and avoiding non-essential travel or large groups. When we talk about Fabry disease specifically, most of the experts have gotten together and determined that really it's important to keep your Fabry specific therapy going. Keep having appointments, keep doing enzyme replacement therapy or chaperone therapy, continue your dialysis if you're getting dialysis for kidney function. Take extra precautions and your healthcare providers will help you figure out how to have the safest treatment course when you're going through to have what you need. If you are in a time where your particular area is having a whole lot of problems, a very high rate of COVID disease, and the hospitals are overrun, it may be that someone has to stop therapy for, a month while things calm down and the burden on the healthcare system decreases. But this is something that each individual can talk about with their doctor. They can talk about the option of home therapy and talk about precautions that they can take into continued therapy. What about vaccines? Well, with Fabry disease, we've done a lot of talking amongst experts in Fabry disease and healthcare providers to try to understand, is there any evidence that there'd be a problem with someone with Fabry disease and the vaccines that are out right now? As you know, there's different types of vaccines that are either here or coming soon. The one that's here in the States is the mRNA vaccine, one made by Pfizer, one made by Moderna. And so far, the evidence is there's no additional issues in patients with Fabry disease. But you should still talk to your physician, your healthcare provider, about any other factors that might make you want to wait to get a vaccine or might have a change in whether you need a vaccine right now related to antibodies to COVID-19, if you've got an allergy to polyethylene glycol, which is part of an mRNA vaccine. Or is there anything else like very low white blood cell count that may mean that you need to delay getting a vaccine? If not, this would be something that would be really good to go ahead and get when it's available for someone in your risk group. All right, COVID. I'll take more questions on that as we get to the end, but let's talk about some other cool things we learned at World this year. One interesting thing is we always talk about how the gene change can lead to symptoms, different types of symptoms in Fabry disease. And they did a really deep and interesting dive and the Canadian Fabry Disease Initiative into a mutation called A143P. Now, this is a mutation that's found more in Nova Scotia and then in Canada from an original founder mutation, from an individual who had Fabry disease and immigrated into Nova Scotia and then had children. They found that this is a severe disease. It's considered a more classic disease. It's the most common gene change that causes Fabry disease in Canada. They found that it definitely, survival with individuals with this gene mutation is better on ERT, with greater than 15% of males surviving over 60 years. They found that if you look at men with Fabry disease who have the A143P mutation, they find that they tend to have higher levels of GL3 or lyso-GL3 in their blood and urine. And men who have high levels of certain versions of this GL3 or lyso-GL3 in their blood and urine are more likely to have different events. And events we usually mean heart disease or renal failure or strokes. So there's certain things that need to look at, and you can make a profile of the GL3 and lyso-GL3 if you have a lab that can do that for you. And they might be a better way of predicting if someone who has A143P is more likely to have a health event. So that was interesting. It's always interesting to look at one population within Fabry disease and see what else we can learn. Just one second. There we go. All right, power. Power is important. Okay, what else did we learn? You remember we talked about podocytes as those deep filtering units that are found in everybody's kidney, and that GL3, that lyso-GL3, GB3, that gunk can build up in those filtering units and cause it not to work as well. So it's not doing as good a job of filtering all of the urine that we need to figure out what stays in or moves out of our body, the blood and urine. When they did find something very interesting. In the past, they found that women who have cells that may be next to each other with podocytes, one may have enzyme, one may not have enzyme. It turns out those cells did not share well. They need to go back to kindergarten and learn how to share better. But they also recently found out, Najafian and his group found that some podocytes will share lysosomes and the enzyme in them by building tiny tunneling nanotubes. They're little tubes that provide things from one cell to another. And when he took those cells and he put them in a test tube and he looked to see, can we make these cells make these tunneling nanotubes? Can we make these cells share their lysosomes? He found that there was a way to do it in the test tube. So he's really interested in looking later down the road to see if in humans we can stimulate cells to share better, because the more that cells share the enzyme in them, the better it'll be to get a therapy throughout the entire body and help cells share the amount of alpha-galactosidase enzyme they have in one with another. So now that we've learned about these tiny tunneling tubes, let's talk about Fabry in the heart. One thing that can be very useful at understanding how well a therapy for Fabry disease is or is not working can be to understand the different stages that a heart gets damaged by Fabry disease over time. And there is one group that came out of the UK that in this most recent world meeting put together an abstract to see if they could, with cardiac MRI, look at their population of patients and determine how the progression is and what signs can you see on cardiac MRI that tells you where in this progression you are. So they came up with, no signs, which they didn't really put on their scale. And then they moved through different stages where you don't have enlarged left bottom part of your heart, the left ventricle not enlarged, but still causing problems with rhythm and how the heart functions. And then moving into the storage where you can see storage, and then into the point where you can see left ventricle hypertrophy and some inflammation, and then lastly into an area where you see fibrosis or scarring in the heart. Now, this is mostly important to know because if we can start staging hearts, we can say, okay, when the heart gets to this stage, can we treat it and it gets better? When the heart gets to this stage, does this treatment work better to get it back? So this is, to me, just a way of leveling the stage so we can understand how well a particular treatment might work. How about Fabry and hearing? When we talk about Fabry and hearing loss in patients with Fabry disease, there's some things that we understand really well, but it's still nice to go through a population and see how much we can define what's going on and see if treatment has made much of a difference. So one large group out in, this is the Danish national cohort, they looked and they saw that hearing loss in patients with Fabry disease is worse when you're at high frequencies. They found that men have more hearing loss than women. And they found that if you just have enzyme replacement therapy, it doesn't seem to help so much with people's hearing. Now, they did find that when they looked at levels of biomarker GB3 in the blood, that they could see lower levels, so treatment over time theoretically would have lower levels. They do see less hearing loss. So does that mean the earlier we started therapy, the lower we got the GB3 levels, does that mean that then the hearing could be less damaged? I don't know. It's a good hypothesis, and they'll see over time if that pans out. They did have one little case report. A case report just means they had one patient they looked at really closely. And they found that in one patient who was given enzyme replacement therapy and chaperone therapy, it did seem to stop the progression of hearing loss. Now, don't go run to your doctor and see if you can try that. Not only, I'm not sure that everybody would have that, that ability to get both those therapies, but in one person, you can't really say this is a done deal. That just means that more studies are needed to see if maybe enzyme replacement and chaperone therapy together might help with hearing loss over time. There's another study that we're looking at. This is from the Fabry Registry database. And what they tried to learn from the sub-registry was if you're on enzyme replacement therapy, in this case with agalsidase beta, does that increase the risk for pregnancy complications or problems with the baby after birth? And the way they did this was they spent a lot of time collecting data, and they were able to get 33 pregnancies in 29 ladies who were treated during pregnancy. And they looked for the pregnancy complications in those women, and then they looked at a group of ladies who were pregnant, had Fabry disease, and weren't on ERT. And then we can look at them both and see if there were more safety concerns that we had. Did we see more complications with the baby, more complications with pregnancy, anything else that would make us worried? And generally the way we think about it is we're looking for a pattern, something that seems to be happening more in women who are on ERT during pregnancy than not on ERT. And what they found was no increased risk of major birth defects, no increased risk for miscarriage, no increased risk for maternal fetal outcomes that were a problem. This is great news. It's a small subset. It's just a limited amount of ladies who were pregnant and had enzyme replacement therapy, but it's comforting to know that if your healthcare provider determines that it would be a good idea for you to stay on enzyme replacement therapy during your pregnancy, there were not increased concerns that there was a problem with the pregnancy or the baby based on this. So it's nice to have a broader subset of pregnancies that we could look at who had been on enzyme replacement therapy. This is one of those studies that you guys know backwards, forwards, and upside down. But sometimes it's really important that you do a study and publish it so that people understand it better. And this was looking at the burden of illness in Fabry disease. And they did this looking at a database of the German Sickness Fund database. So it's a large set of information on people and their claims and when they've been to the hospital and what health problems they've had. And then they compared people who have Fabry disease to people who didn't have Fabry disease. Based on the coding, right? So that if they could only do this if the doctor coded the individual as having Fabry disease. But what they did find is that more people with Fabry disease, 14%, had more than one sick leave during the whole time they looked at this fund. They found the hospitalizations were more frequent and longer in Fabry patients. And they found there was a higher burden on health with Fabry disease patients than control people they're looking at in Germany. You might say this is not a shock to me. But again, it's good to know that we have this systematically written, because if it's not written down and people can't look at it, they don't realize what you see in yourself and what we would see in clinic. This was a really interesting study because it came more important with chloroquine. So this is the group out of Pittsburgh. They were looking at individuals before they were diagnosed with Fabry disease who were put on hydroxychloroquine for misdiagnosis of a rheumatic illness, so for an autoimmune condition, and they gave them hydroxychloroquine to treat the illness they felt they could have before they realized it was Fabry disease causing symptoms. And they had 4 patients. They were all ladies and they all had Fabry disease and they were diagnosed. And then they said, okay, since we got you diagnosed with Fabry disease and we're treating your Fabry disease now, we don't know that you need to be on hydroxychloroquine anymore. So they looked at these patients very closely, and 2 of the patients they looked at, they could see they were already having adverse reaction to hydroxychloroquine. Because the way that hydroxychloroquine works is it interrupts how well your enzymes work in your lysosome. So Fabry disease is already interrupting how one enzyme works in your lysosome. And then you take hydroxychloroquine, it interrupts all the things that are happening in the lysosome. So you combine them and you can see 2 folks who ended up with muscle problems, myopathy, muscle problems. And they also had the elevated creatinine kinase levels to show it. So one of these ladies had Fabry disease. She was on hydroxychloroquine. They stopped the hydroxychloroquine, but this damage that was done from being on the medication, the damage to her muscles, ended up continuing on and causing problems for her, and she passed away from that issue. And they looked at the other 2 patients that weren't having problems of hydroxychloroquine toxicity or Fabry progression. They went ahead and stopped it, and the disease symptoms they were being treated for did not come back. So the bottom line here is hydroxychloroquine is sometimes used for treatment of autoimmune disease, and more recently it was proposed to treat COVID disease. In either case, if you have Fabry disease, this is not a good option. If there's any other medication you could take, this would be one to avoid, because its mechanism combines with the mechanism of Fabry disease and leads to health problems that could be above and beyond Fabry disease related to the muscles and how they function. So it was important news. There also was an interesting publication that was from John Jeffries that he presented, and there's other companies and people working on this as well. How do you take artificial intelligence and apply it to these large data sets we have, whether it's medical records or if it's data that you can get that, like he was looking at, that's just big data sets of symptoms and health problems. And how do you find patients with Fabry disease or other genetic conditions? And so he did this interesting study where he looked through this large population of 5,000 patients with Fabry disease with specific data points and compared them to control patients to see if he could identify those with Fabry disease, just patterns that we could find that would help us then use large other data sets and figure out who's at risk for Fabry disease. And he found a large incidence of people, larger than we'd expect, who could be at risk for Fabry disease and would benefit from diagnosis and treatment. And there's other companies working on that as well. Okay, so what did we learn at the World meeting about some of the FDA-approved therapies? Well, from the FOSS registry, they've got 20 years of data now, and they found two interesting findings that they presented within their poster. One was that individuals who are on agalsidase alpha show a slower annual decline of the eGFR, and eGFR is our measurement of how well our kidneys are functioning. They also found a slower rate of increase of the left ventricle myocardial index, I think it is. Anyway, their heart was increasing much slower than the control population, and their kidney function was decreasing a lot slower as well. So in both cases, heart and kidney appeared to be stable or improved. Oh, look, it's time to go hop on the call compared to the natural history before. When we look at agalsidase beta, there were two studies that were there in poster, one presented and one not. One is that, again, focusing on the kidney, and they found adult men with classic Fabry disease just starting ERT had fast clearance of GL3 from the podocytes, those deep kidney filtering cells, over the first 5 months of ERT. But it didn't completely clear them out, and then the next years of therapy didn't seem to clear them out very quickly. It was very slow, and there was still GL3 remaining in those podocytes. So they don't really understand right now why a lot of the podocytes or a chunk of the podocytes clear partially quickly over the first 5 to 6 months of therapy, and then after that slowly start losing more, but really not getting to zero in these men with classic Fabry disease. But if they can figure out why, then they can figure out how to make it work better. The other look is a look at the Fabry registry data in men with classic Fabry disease. This will sound very familiar. They found that you treat with agalsidase beta, enzyme replacement therapy, stabilizes eGFR decline, so it gets a little better, and it improves the thickness of the septum between the two parts of the heart and the thickness of the left posterior wall, compared to what you'd see in individuals before they started enzyme replacement therapy. So again, good news for ERT, similar to what we saw with agalsidase alpha. Being treated seems to assist with heart worsening and kidney worsening. Although, they used different measurements and they looked at a different set of individuals. One thing that we're really focusing on more, particularly at World, is how do you address infusion reactions when you're on enzyme replacement therapy? Why do they happen? How do we address them and how do we make them better so that people can better benefit from enzyme replacement therapy? And there's one study from Dr. Alpan's group that looked at 6 patients who were having infusion reactions, and they looked really closely at the immune system. They looked at the types of cells to see if they could learn a little bit more about how those cells interact and lead to the infusion-associated reactions that she was seeing. Most of these folks didn't have IgE antibodies. They had neutralizing antibodies, which are related more to IgG. And when they looked at them, they found that there's a couple of things. It may be that this inflammatory response to cytokines is causing some of these problems. And there's something related to the mast cells, a particular type of immune cells, and how it leads this inflammation. But it's not related to IgE, it appears. So in this case, for these patients, they were able to treat, and when they treated it, they were able to continue enzyme replacement therapy. But they used a combination of what we'd usually use, which would be your Benadryls and your steroids. They also used medications that are called mast cell stabilizers, and those helped as well. So again, still trying to figure out the best way to help enzyme replacement therapy work best in the body, even with some immune reaction. Migalastat, the chaperone therapy. When we talk about migalastat, there was one poster that was there at World this time, and this was looking at the long-term benefit of being on migalastat for the individuals who were in the study previously. They found that these patients had previously, they reported that their heart, the size of the left ventricle heart, had reduced and continued to stay low. And in this study, they showed it continues to stay the way that they thought. So the positive impact on the heart of taking migalastat continues out over these patients who moved into these long-term extension studies. They also found that it was generally well tolerated, which means they didn't see a lot of problems, no adverse events that were related and systematic and caused people to stop taking the medication is the bottom line there. These other data here beneath, I just left in from last year's World meeting just because I thought it was still important to know that after 6 months of migalastat therapy, men and women with minimal mutations had reduced GL3 storage in the kidneys, in their podocytes and their capillary. So these are things that, again, showing the heart and the kidney responding well to a therapy that's out there for us. So we mentioned briefly in the hearing study that sometimes there's some case studies where we see that someone takes enzyme replacement therapy and chaperone therapy, and you want to see what happens after that happens. Well, in this case, a group out of Mount Sinai said, well, we can get this one patient enzyme replacement therapy and chaperone therapy together. And if we were to get them both these therapies, will that help this person who has severe heart disease stabilize? Not necessarily get better, but can they stabilize it? And they found after 1 year, this patient who had enzyme replacement therapy, when they gave him both enzyme replacement therapy and chaperone therapy, it really helped him out in stabilization, at least for that 1 year. Now they did put an internal defibrillator in, just in case he had an arrhythmia that could be life-threatening. But in this case, they just showed that, again, maybe more studies are needed to look at enzyme replacement therapy and chaperone therapy together. So that's 2 case studies that show that there may be some benefit of both of them together, but it didn't in any way look at how that's going to get paid for or how we would do a more systematic long-term study on that. We'd have to figure out what thing we want to look at most. Is it hearing? Is it heart? Is it kidney? What are the things we need to look at, and how do we measure if it's improving things to the point where this would be a good option? Another thing, so out there in the world, you guys may have realized there's a tablet that you can take that's a dietary supplement that's alpha-galactosidase A. Now, this is meant to be taken as a pill for anybody, not just Fabry disease, and it's supposed to help with, digestive upset, like flatulence, which that would be gas and farting, abdominal bloating and stomach pain, or distended stomach. So one group, the Linder's group, said, well, how does this help in someone who has Fabry disease, and how can we systematically really closely look at this? So they got 5 men and 2 women together who had Fabry disease with a mix of different gene mutations. They gave them 1,800 units of alpha-galactosidase A tablets over 50 to 180 days. Some of these folks were on enzyme replacement therapy too. Some of them were not. All of them did have GI symptoms. Mostly they focused on their flatulence, their abdominal pain, and their diarrhea. And they found that out of the individuals who were on it, there was 3 men who had a decrease in lysoplasma GL3, whether they were on or off therapy. There was 1 man who was not on enzyme replacement therapy who actually had an increase in plasma alpha-galactosidase levels. That's kind of nice. And all patients reported a decrease in intensity and severity of their GI symptoms, again, focused on diarrhea, abdominal pain, and flatulence. That's a pretty exciting news, but again, small scale study, and it's something that could be investigated further. But in the meantime, that could be something that individuals, if they are having continued GI issues, could talk about with their healthcare provider to see if this might make sense to do a trial or not. Again, that would be a 1-person trial, but we've heard about this before in the past from individuals trying it, saying it helped or didn't help them. But this is nice to have at least a systematic study that really went in very depth with looking at the enzyme that they had from individuals and how this might work. In the past, we've always thought that the digestive system wouldn't absorb enough alpha-galactosidase A to help, but maybe this is showing that there is some that still gets through. Okay. Fairly quickly, so we have some time for questions, let's talk a little bit about some of the therapeutic targets that are going on now. Idorsia Therapeutics has a substrate reduction therapy study that they're looking at. It recently closed to enrollment, and their poster this time, their information they were giving was really on how do you manage a trial and still continue it going to be safe, to help patients and still get the data you need. And so they gave a nice poster on how they were able to do that. When we looked at enzyme replacement therapy with PEG, uganidase alpha, this also was doing therapy during the time of COVID, but they were able to present some data on the individuals pre-COVID which was a study that looked at switching from Replagal for people who've been on, or for agalsidase alpha who'd been on for 2 years, and then switching them to pegunagase alpha to see how they did. And this was data on 20 individuals, 13 men and 7 women, and they were on study for 12 months. And they did see that it was well tolerated. There were 2 individuals who discontinued related to infusion-associated reactions or treatment-emergent adverse events. They did find that though over 12 months, the plasma lyso-Gb3, the levels decreased from baseline by 31.5%, and the mean annualized eGFR slope, how well their kidney was doing, improved. And they had 2 different populations of people whose kidneys were getting, their GFI was getting worse a little quicker, and one was going a little bit standard. And they found that 75% of people whose were just having standard declines in GFR did better, and 66 of the rapidly getting worse eGFR patients got their therapeutic goals. All that boils down to is it looked like good data for pegunidase alpha here in the United States. This particular medication is currently being reviewed by the FDA based on other data, but this was nice to see some data on what's going on with this particular medication. Gene therapy, as you know, gene therapy is very exciting, and there's multiple people working on this. The real goal is to find the best method to get enough enzyme in the body to help the body produce enough enzyme on its own. So you can just do it once. There's different types of vectors, which is how you get that gene into the body. And the way that you know it works is you've got increase in alpha-galactosidase levels, decrease of GB3 or lyso-Gb3, and maintaining or stabilizing kidney and heart disease with minimal side effects and no big immune reactions. And then we want to know how long does it last. So you've got AVROBIO, you've got Sangamo, Freeline, 4DMT, and many other people working hard on these particular goals to get gene therapy working. There was some very nice data from AVROBIO, who's working on their phase 2 study. They closed, their phase 1 is completed. Now they've moved into phase 2. They found that everybody who was on the study, TEAE is the fancy way of saying people who had problems while they're on the medications. So because they were on and they were considering these problems to be related to the drug. I know that one's a little weird. Most people call it adverse events, but that's how they chose to label it for the last one. And that's something we look for in all the different studies, is what adverse events happened, and are they related, do they appear to be related to the study drug or not related to the study drug? So for AVROBIO, again, the phase 1 and 2 results showed increases in alpha-galactosidase A, both in plasma and leukocytes, and decreases in GB3 and lyso-Gb3 in plasma. And that was in the person who was in the people in the phase 1 study, who've now been on that for 42 months, and the people who are in the phase 2 study who have been on it for 22 months. So that's great news. They also found the estimated GFR was positive trend, so stable function up to 32 months, which is wonderful because everybody has a decreasing GFR over time in Fabry disease, depending on whether you're going kidney function's getting worse quicker or slower. What we really want to see is stability, and in a perfect world, we get some improvement. But if your things are already okay, then we can go from there. They did a kidney biopsy at 48 weeks after therapy for the first patient in phase 2, and they found an 87% reduction in the capillary inclusions. And the adverse events that they saw, adverse events being health problems that have happened to an individual in a study. And these health problems are either related to the study, related to something related to the study, like in this case, conditioning regime. So the medication they took to decrease the immune system before they gave the medication back to them. They were all mild to moderate, and they were quickly resolving. So in this case, the adverse events they saw were less related to getting the drug and more related to the dampening of the immune system and the medications used to do that. But as you see here, it was well tolerated and did well. The adeno-associated virus studies didn't present any data at this particular meeting, but if you look at their clinical studies, you can see that there's open and they're going and enrolling. And so we'll see in the future what's going on there. Interestingly enough, in Taiwan, they're working on a gene editing, which means they're actually trying to correct the gene change that's very common in their population, but they're still, you guys, in skin cells. They're not even to mice yet, so they'll get there, but this is just something to watch. And for individuals who've tried to be in the clinical trial, and found that they had antibodies to an AAV, because AAVs are, the vectors we use are also originally related to infections you can get. So you can get the flu virus, you can also get an adenovirus. And then from that adenovirus, you can then end up having an antibody, which means they wouldn't necessarily want you to have gene therapy with that adenovirus because you can have an immune response to it. Well, there are some people who are working, Jeffrey Alexander presented in this case, the work that they're doing that is a molecule that cleaves the antibodies that are against the adeno-associated virus. And by cleaving it, it means it's not going to work. So they've used it in non-human primates, that would be your monkeys and your apes, and they found that they are able to cleave those antibodies, and then you could get gene therapy if you already had a reaction in the past in antibodies to AAV. And they've cleaved them, so in the past, if you got gene therapy and already had antibodies because of your last gene therapy with an AAV, you could possibly get them again, which could be helpful if one became better or one needed to be longer lasting or you needed a boost, 5 years from now, 10 years from now. So that was really exciting for individuals who already have antibodies to a vector that we're looking at in one of these companies. Okay. So that was my run through. I'm sorry that was a little faster than perhaps I'd usually do, but I am absolutely open to all your questions. I think we're putting in the comments, but I'm happy to see them live as well. And I'd love to hear what you're thinking or what I can help you understand a little better.
Thank you very much, Dawn. I will say that's very positive and lots of great news. You have a really great way of simplifying this and explaining it, so thank you so much. I see that you weren't the only one with a time zone issue, because I see that we've had some new joiners in the last few minutes here, which means that they're joining now. So for anyone that just joined, this has been recorded, and I believe it's going to be on the FIN website, so you can find it there. Also, if you have any questions for Dawn, you'll see in the right-hand corner there's a little chat. Please feel free to click on that, and then we can talk about that as well. Personally, I found it very interesting about the alpha-galactosidase oral that helps the GI, and I think that's something that's so easy for all of us to do. That's just like a takeaway for me. Why not give it a try? You can be your own judge on how well that works for you, right? So.
Yeah, I would say that check it with your doctor just to make sure there's no reason you shouldn't take it, to make sure it doesn't react to anything else that you're taking. But this is a study that I really wanted to do years ago, but it's hard to get funding for something like that. And I think that the level of detail that they got looking at biomarkers, looking at the enzyme levels and kind of cutting it down and breaking it down was a level that I couldn't have taken it to then. So I was really happy to see that study. I know there was one other really small scale one that was done a couple of years ago. So I think it's something new and interesting to look at. And I think it's particularly important to figure out also when you take one of those tablets, how much quality goes into that. So you're always getting the same amount of active things in the body, or is it something that you see that maybe varies a little bit, because these supplements are not regulated as much as our prescription medications. So I think it may be worth, having somebody do a chemical analysis and see how much you're getting when you take it, and does it matter how you store it and how it was stored at the school, or the store. I think it's really interesting.
And also the what I noticed was that the amounts were quite high in the study, because it was 1,800, and I think I checked online that usually one tablet is 400
That's
units.
Right. It was a high dose.
So you need to take like 4 or 5 tablets to reach the daily amount. So that's that's quite a lot.
It is. It's a lot, and you don't know if there might be some other side effect related to taking that much too.
I know. So
That's why it's worth looking into and seeing what's going on. That study was performed on classic men and women combined together, so it was an interesting mix of mutations. So again, every time we try to say oh, was it classic men? Was it classic women? Was it non-classic? How do we know based on mutation? It gets less and less significant when you look at results, but you have to start somewhere. So I think this is something that working with your doctor, you could think about trying in a man who's classic or a woman or someone who's non-classic. I think you could try it for anyone. Interestingly enough, they did have one control who was someone who didn't have Fabry disease. And when they took this pill, their natural alpha-lactosidase A in their body increased. So even though they didn't have A, taking this increased it in their body, which I thought was very interesting.
Yeah, that is interesting. And I do think that you already answered, you already touched on Erica's question, but TEAE was,
yes.
I'll let you know that one, yeah.
Yeah, treatment emergent adverse events. That's how, who was it? I think it was Pertalix was describing their adverse events. Treatment emergent adverse events is really just a way of saying this is a health problem that was associated with the study drug. So they're saying this is something that happened after they were on the study and that the doctor considered related to the medication. Because you could have, when you're in a study, if you stub your toe and you take a Tylenol for it or an acetaminophen, that's something that we record as a study coordinator. We write down, we're like, hurt toe, took an acetaminophen, and then the doctor who runs the study says, is this related to the fact that they were taking a medication, or is it related just the fact that they didn't? And in many cases, these are all unrelated, but these are ones that they considered there after they started the therapy, and they considered it related to the therapy. An adverse event is, again, just something that happened with somebody who was in the study, some health event of some sort. So I hope that's a little clearer. I know those terms that we use a lot in research, and it just gets more confusing. Yeah, whether you're a native English speaker or just not a native English speaker, they get complicated, the terms. And that's one of the reasons that I like to talk about ahead of time, just getting on the same page with some of the general Fabry terms, so that when I use it, you know what I'm thinking about. But when we talk about specific studies, each company uses their own terms, and then I have to think about describing those as well. So thanks for reminding me. What other questions do you guys have?
I have another question. This is Anna. Regarding the Danish study on the hearing loss.
Yes.
You mentioned that men are actually more affected by hearing loss in general than women. Is this something that, is because I've actually never heard that before. So is that something that is that you've heard before as well, and not only in this study?
It's something that I've seen in clinic. Yeah. So I've seen that the men with classic Fabry disease, they're more often the ones that are going to need additional, like they have more profound hearing loss. So they're the ones who are getting cochlear implants. Those are the ones who are getting the more heavy duty hearing support. So your hearing aids. Absolutely women have hearing loss. Absolutely women have that ringing, that tinnitus that you can hear, but I see more profound hearing loss in the men. I mean, again, it's all on a spectrum, so I do absolutely see women who are as severe as the men, but if you counted up the number of men in our clinic who have hearing aids, cochlear implants, we would, after age 40, I would say that it would probably be like 4 men for every woman who's at the same hearing spot. And I think the higher or lower GB3 levels, I'm not sure how much that'll pan out, because when you look at women, those GB3 levels don't seem to correlate really well with how severe their symptoms are, just because, women are like calico cats and have patches of enzyme throughout their body. And if you're measuring GB3 levels in blood or serum, usually plasma, so out of the blood, I don't know that it's going to give a good connection to what we see in hearing loss or other symptoms. And I think that's what we're seeing here with this change here in the men, a little bit more straightforward. All their cells are making the same thing. And so you can see lower levels or higher levels and correlated with the hearing loss.
Now, Dawn, I know that we talked about 2 patients that were given ERT and chaperone, the combination therapy. Do you know of, is this happening, is there more than just 2? Is there a lot of patients that are getting this globally?
Yeah,
or
that's a great question. I would say no, probably not a lot of people getting that. I know that in the past there were some companies who were thinking about doing studies more formally in that. I haven't seen those come to the world of clinical trials yet. And I think that's just because, you've got to focus on one thing at a time. It's expensive to do a study. I think it's just kind of randomly the opportunity comes up every now and then. I know that in the States, when I fill out a request for enzyme replacement therapy, a prior approval, so that the patient can get the enzyme replacement therapy, they're now asking if they're also going to be taking a chaperone therapy. So I've got to fill out that box, yes or no. And I think it would go to a higher level of oversight if I said they were going to take chaperone therapy plus enzyme replacement therapy. So I would say not very much, really on a very limited basis, and I think very much on a research basis. And I think I would love to know how people were able to get both for their patients. If it was something where they asked for access for a study from one company or the other company, and then clinically, charged to insurance the other one, I think it would be hard. But I think it's something that really needs to be studied. So I think we'll have to work with the company to see what we can do.
Yeah.
But also thinking of once in the real world, thinking of the financial burden that,
Exactly.
combining treatments like that would cause. So it's a little iffy in that sense.
I know that there's in Pompe disease, which is one of our cousin diseases in lysosomal storage diseases, they are doing clinical trials where they're giving chaperone therapy and an experimental enzyme replacement therapy to see how it goes, or they're giving clinical enzyme replacement therapy that's approved plus chaperone therapy. And if they packaged it and the pricing was such that it was not like giving both medications, I think that would be a big difference. So we'll have to see how the pharmaceutical companies are going to handle that as we move forward, because as you said, the burden is going to be too much if you've got one person trying to pay for both therapies and they both cost, large amounts of money.
Any other questions for Dawn?
Julia, can I speak?
Please, yes.
Hi from Greece. Doctor, thank you very much for your nice presentation. Very clear. I would like to point out the triangle from the study that shows the severity for Fabry patients and the coronavirus. That was interesting and very, optical. I think it could be helpful for some centers around the world that treat Fabry patients to have their mind on. And the other thing I would like to point out are the supplements. That was really, really interesting to know. And I'm doing that for over a year. So yeah, I can see the benefits of taking them. Yeah.
Excellent.
Thank you.
Do you take the 4 pills, or are you taking less or more?
I'm taking 4 per day, 2 in the morning and 2 in the afternoon.
Interesting. So you split it up. You don't do all at once.
Yeah.
Interesting. Yeah, I think that there's all things that we need to look at more. This particular triangle of severity is it within a published paper now. So if you look at Fabry disease and COVID-19 on PubMed, you can get right to it. It's available so that we can share it. And if you can't get a copy, feel free to email me. My email is easily found.
I write it down, don't worry. Yes, thank you very much.
Yeah. And I'm happy to share that. It was just an international effort, and we started it right after COVID struck, and then we realized that we really wanted to get an international group of people to really understand how it's affecting people around the world. And that was really nice to be able to work all together and put together something like this, which could be useful in clinic as well as reporting what was happening.
Exactly. Thank you very much.
Thank you.
Any final questions for our speaker?
Well, I'd like to thank you guys so much for coming and listening. I hope that my translation of what happened at World makes sense, and that I focus on things that were important to you. It wasn't really a year where there was a lot of focus on things presented about Fabry disease, but there was some really great posters. So I enjoyed going through them all for you guys to kind of distill what I could find and bring even though it wasn't presented at the main meeting.
Dawn, thank you so much for your time. We
Sure.
really appreciate it. And for everyone that joined us, thank you for being here. Again, this has been recorded, so you can find it. And if you have any trouble, just reach out to any of the FIN members and we can guide you in the right direction. We will be having our our Fabry International meeting on April 24th. And we will see Dawn's friendly face there again as well. And so, yeah, we're really grateful for your time today, Dawn, and you have a great way of breaking down complex things and explaining them to us. So thank you very much.
Thank
Luz,
you.
I'm not sure if you have
And everybody joining me.
Okay, take care, everybody. Thank you so much.